All right. All right, guys, what is up? This is NPTE Night School Season 2. This is my 11th video total. I today decided I wanted to go over 15 questions. We're going to start with some integumentary system, then we're going to move into some endocrine system, and then we will finish with some neuro questions. You'll have to forgive me because my daughter is having a difficult time going down to sleep these days, and we just have to let her cry it out, so hopefully she won't be too distracting to you guys. But if you guys have not joined my lives before, I am Austin Miller. I'm the Neuro Nerd PT, and every Sunday at 8 p.m. Central Standard Time, I put on NPTE Night School, where I gear questions towards the topics that you guys are struggling with the most in your practice tests and in your preparation for your NPTE. Obviously, the next NPTE coming up is the April exam. Our PTAs have it, I want to say it's like April, somewhere between the window of April 5th and April 8th. And then our PTs will be having the test further down the line. I want to say it's somewhere between the 26th and the 29th of April. And so we have several weeks between now and then where we can cover as much content as possible. Again, I care about covering topics that you guys are saying that you need more help in. And so today, I remember a couple weeks ago before I took my 2-week break, there was a gal on here who was saying that she wanted to focus more on integumentary, and I know that endocrine can be tricky for some people as well. My first love is neuro. That's why I'm Austin Miller, the Neuro Nerd PT, and so that is why I love incorporating neuro as much as possible until you guys tell me that you don't want to do neuro anymore, and then I'll do something else. Northgate, what's up, dude? It's good to see you. Okay, so let's go ahead and just jump right in. The first 5 are going to be all integumentary system. The second 5 are going to be all endocrine system. And then the third 5 are going to be neuro. So let's get started. A patient with a stage 3 sacral pressure injury presents with 60% yellow slough and 40% granulation tissue. There are no signs of infection. Which intervention is most appropriate to promote wound healing? A. Wet to dry dressing changed twice daily. B. Sharp debridement followed by moisture retentive dressing. C. Non-selective mechanical debridement using pulsed lavage or pulsatile lavage. Or D. Occlusive hydrocolloid dressing without debridement. Uh, Personally, I think it's really important when we're studying that we are actively engaging in the material. The reason being is that studies have shown if we have an active engagement with material, even if we get it wrong or we get it right, it's going to stick better in our brain. We're actually making neural connections, even when we're doing something that seems passive, like hitting an answer choice, right? And so I encourage you all engage, submit an answer choice, and I will go over the answers, why the right is right and why the wrong are wrong. And so the more you engage, obviously the more it helps me as a TikTok creator, but I don't care too much about that. I don't really ask that you guys send me any sort of money or anything like that. I do all of this for free just because I like it. But the more you guys engage, the more it's going to stick. So if I am starting to explain something and you're like, that didn't make a whole lot of sense, feel free to like ask for clarification. The more you engage in that regard, the more that it's going to stick. This means nothing to me unless you guys are learning, right? And so please help me to learn how I can facilitate your learning as best as possible. So I spent a lot of time talking. Several of you have submitted answers already, so let's go ahead and go over what the right answer is. So the correct answer is B. So obviously, when we have slough or any type of necrotic tissue, even if it was, oh my gosh, eschar, uh, if it's not covering the whole area, then we probably want to do something like sharp debridement. The reason sharp debridement is such a good choice is because it's selective. So you can really be intentional about which, I hate that I'm back here. I know, user, I'm so sorry. I'm sorry, but I love to see you, if that makes you feel any better. Um, but sharp debridement, you can be selective, and so you're not going to run any risk of hurting that good granulation tissue that you want. If we did wet to dry dressings, that's non-selective, and so basically what you're doing is you're throwing on something to soak up all the moisture, letting it dry, and then ripping it off. So you're going to damage the granulation tissue with wet to dry dressing. You don't want to do non-selective mechanical debridement using pulsatile lavage either, um, because it may disrupt that viable tissue as well. The reason you don't want to use occlusive dressing without doing anything about the necrotic tissue is because it can promote bacterial growth, which can then lead to infection and all of that stuff. Would NPTE ever give you a 50-50 scenario? There's going to be a lot of times, if Nicole, if what you're asking is, there's probably going to be a lot of times where you narrow it down to two questions and one of those answers is the best answer. Okay, so it's important when you're practicing and when you're taking your practice tests, mark those questions, because even if you get it right, it's important that you review those questions so you know why you got it right, especially if you know, like, I was 50-50 on this one and I guessed. Go back, study the rationales, so that way you're like, okay, now I understand why that one was right. Yeah, of course. They won't ever give you one where it's like either of those could be the right answer. Like, for sure could be the right answer. Most of the time, they're going to tell you, like, choose the best option, right? Especially in all of your prep work. So I don't know that I actually explained this really well, but slough requires removal for optimal healing. You want sharp debridement because you can be intentional about preserving the viable granulation tissue. Okay, so that's why it's A, or sorry, that's why it's B. But yeah, no problem, Nicole. If you guys happen upon a question, PT is in physical therapy. Yes, ma'am. Will you do any cardiopulmonary questions? Got an exam Tuesday and love practice questions. I won't tonight, Nicole. I actually have just integ, endocrine, and neuro planned for tonight, but I do this every Sunday at 8 p.m. Central Standard Time. And so if you guys have particular content area that you want me to cover, I try to cover multiple in the night so that way we get like the most bang for our buck. If I'm interested in that, I want to take care of you. Awesome. That sounds cool. But yeah, so let's keep on going. If you guys have questions, feel free to ask along the way. A burn patient presents with partial thickness burns covering the anterior trunk and entire right arm. Using the rule of nines, what is the estimated total body surface area burned? A, 45%, B, 18%, C, 36%, and D, 27%. So, like I said, feel free to engage. It's going to help it stick better in your head if you do engage with the material. It's better than just being passive and sitting there watching. Not that I'm not saying that that's not useful, but research has shown that the more we actively engage in learning, the more it's going to stick. This question in particular is all about knowing your rules of nine, right? And so you need to know which portions of your body are estimated as which percentage of your body's surface area in order to get this one right. Okay, so let's go over it. I'm just gonna tell you before I reveal the answer. So we know that they've got partial thickness burns on the anterior trunk and right arm. Okay, so when we're looking at the arms, the entirety of the arm is 9%. Okay, they call it the rule of nines because basically everything is uh, divisible by 9. So you've got your arm, which is 9, your head, which is 9, your other arm, which is 9. That's 36% total. You've got the front portion of your trunk, which is 18%, and then the back part of your trunk is another 18%. Okay, right leg is 18%, left leg is 18%. So we got 36, 36, which is 72. We already said 9, 9, 18. That's 90. 9% is your head. That's 99%. And then external genitalia is 1%. So that adds up to 100%. So 18 trunk and 9. Yeah, 9 front, 9 back. So that front portion of your trunk is 18%, the back portion of your trunk is 18%. So we said arm is 9, anterior trunk is 18, so our total would be 27%. Okay, so that is how you deal with a rule of nines question. Good job for everyone that said D. All right, number 3. A patient with a chronic venous ulcer demonstrates hemosiderin staining and moderate drainage at the medial malleolus. Which intervention is most critical for long-term healing? A. Intermittent pneumatic compression. B. High-intensity ultrasound over wound bed. C. Compression bandaging and limb elevation. Or D. Whirlpool treatment daily. I will apologize again. My daughter is difficult to put down these days because we get her like dead asleep in our arms when we're rocking her, and then she wakes up the second we stand up. So, um, so we put her down, and basically we just wait for her to cry it out. So I apologize if you can hear her in the background, but she will go down eventually, I promise. But yeah, go ahead and submit your answers, and we will go over it here in just a bit. Let me get a drink of water while we wait. Okay. All right, now that you guys have had plenty of time to submit answers and think about it, the answer is C. Good job to everyone who said C. Didn't look like this was super challenging for anyone. Um, so, venous ulcers obviously result from venous hypertension, meaning like there's a lot of pressure built up in your veins, right? And so we want to make sure that we're effectively addressing that swelling, which is what happens when we have blood just sitting in our veins, right? And so while intermittent pneumatic compression could be helpful in short term, it's not going to be a good long-term primary intervention. It might be helpful as an adjunct, but we really need to do compression bandaging and limb elevation to make sure we're getting all of that blood pooling in our lower extremities back up towards our heart, right? High intensity ultrasound, that's not going to address any venous insufficiency. And whirlpool treatment might actually macerate the area, which could then delay tissue healing. And so the best option here is going to be compression bandaging and limb elevation. If you guys have any questions about any of these, stop me. I do look at the comments, so stop me and let me know, and we can talk more about any question that might be a challenge. Hold on. I was kind of typing these out fast, and I've got some spelling errors. Okay, number 4. A patient with diabetic neuropathy develops a plantar ulcer under the first metatarsal head. Which biomechanical intervention is most appropriate? A. Rocker bottom sole modification. B. Metatarsal pad proximal to the met heads. C. Heel lift to reduce forefoot load. Or D. Posterior leaf spring AFO. Guys, go ahead and comment your answer choice. Feel free to ask clarification questions if you feel like you need to. I don't want to give you too much more than what the STEM gives you, because obviously when you're taking your boards, you're only going to have what the STEM. No. Just let her cry. Let her cry. She'll be fine. Sorry, my wife she feels bad when I've got distracting things going on when I'm doing my lives. And so, but gosh darn it, parenting is important. And Amelia needs to learn, my daughter needs to learn that when it's bedtime, it's bedtime. So, all right, several of you are answering. Very good. Let's see. I'll give you guys a little bit longer just in case you want to submit your answer choices. While you guys are still taking some time, I do want to just plug again. I have taken the last couple of weeks off. That's why perhaps this didn't come across your feed earlier as you're scrolling through your For You page or what have you. But I try to do this, and my plan is to do this every Sunday. I had done it before the previous 2 weeks before I took a break, just so I could get some content developed. But I do this every Sunday at 8 p.m. Central Standard Time. Do you have any specialties or areas you find really interesting? So I actually have my board certification in neurologic physical therapy, so I have my NCS. But in particular, I further specialize. I'm seeking further certifications in vestibular rehab, vestibular and concussion rehab. That's kind of my jam. No, Nicole, you're good, dude. You don't have to apologize. But I do this every Sunday, 8 p.m. Central Standard Time. If you guys are preparing for your April or July boards, or you're preparing for the PEAT that you guys might have to take before you graduate this year, feel free to tune in any and every Sunday. If you have classmates or you know other people in PT programs that you think this would benefit, feel free to share my name with them, share the lives with them, share any of my content on my page. I don't want to ask you guys for any money, so this is not something that, hey, it's good to see you, Luis. um, I'm not going to ask you guys to fund anything for me. This is stuff that I just like doing because I really enjoy teaching, and I know how helpful it can be. Obviously, I'm a PT. I can know how helpful it can be when you're studying for your boards, when that um, you have resources that can help you study for your boards that are free, right? That you don't have to pay for. Jess, I do think this is good for PTAs. I actually, when I started this back in November, I had several PTAs that were going to be taking their boards in the beginning of January, and many of them said that it was helpful. Um, Not that I'm taking credit for any of that. I mean, those are probably very driven individuals, just as I imagine all of you guys are very driven. I just want to be another source of practice for you guys. I don't take any credit for any successes you guys have, because you guys are the ones putting in the work, right? Um, oh, that sucks. Sorry, Mickey. I've just been talking away. But yes, the answer is B. And none of you guys were fooled at all, which is great. There was one thing I put in here just to be a little tricky, but you guys probably saw right through it. So C says a heel lift to reduce forefoot load. Anytime you put a heel lift on someone, it's going to increase forefoot load. And so uh, this is like just a false claim, right? But I'm glad none of you guys fell for that. So the Met head is going to relieve pressure proximally to that first metatarsal, which means that the pressure is going to go proximally to that, and they're going to relieve all of that forefoot pressure on that wounded area, right? And so this is actually a pretty classic way to treat or like improve someone's function and functional gait, so that way they don't continue to get worsening wounds. Thank you. You're awesome. Please keep doing this. Of course, Zamzam. I just love doing it. Um, Now, the rocker bottom sole modification is not a bad option necessarily, but as you can see uh, by the rationale, it can be helpful, but it's less targeted to the area than the Met pad. And so, if we're looking at really just trying to relieve plantar ulcers happening at the metatarsal heads, you really want that Met pad, that Met bar, to take the pressure on before you even get to the metatarsals in the gait pattern, right? If there's no questions about that, we'll move on to number 5. Number 5 is the final integumentary question, and then we'll jump into the endocrine system. Okay? So, which modality parameter is most appropriate for promoting collagen extensibility prior to scar mobilization? A. Continuous ultrasound at 3 megahertz, low intensity. B. Pulsed ultrasound at 1 megahertz, low duty cycle. C. Continuous ultrasound at 1 megahertz, moderate intensity. Or D. Cryotherapy followed by massage. You guys take some time to look at it, answer the question. When would you use a rocker bottom? Um, Depending on where the plantar ulcer is, I could use a rocker bottom. Rocker bottoms are not bad. They're just sort of non-specific in reducing pressure across the foot. Whereas, like you'll probably see a lot of patients who have diabetic neuropathy that just like get rocker bottom shoes at the behest of like their physician, for instance, or their podiatrist perhaps. And so they can be good, like long term. If they don't already have an active wound happening, then it can really help disperse the load throughout the foot so that way they don't develop. But if they already have an active ulcer, then I probably want to be a little bit more proactive in trying to make sure I absolutely reduce the pressure. So that's why I would use a rocker bottom shoe. Good question, Edgar. Okay, C, because we want to target deep tissues. A, this is a tough one for you guys. Good. Woo! Okay, so let's go ahead and go over it. So the answer is C, because continuous ultrasound at 1 megahertz is going to penetrate more deeply into the tissues, and it's going to increase collagen's its extensibility before mobilization. If you're doing, and remember, this is something that, like, scarring isn't something that just happens superficially. If you're getting scarring, it's happening pretty deep. Like, because if you do just the epidermis, if you get a cut just in the epidermis, you are not really going likely to scar, right? Because you didn't uh, cut deeply enough to need those tissues to scar down. So you can basically just get your regular skin cells to heal. But if you uh, are scarring, that means you were cut deeply enough that you're going to need something at a lower intensity, or lower frequency rather, because lower frequencies are going to penetrate more deeply into the tissues. High frequencies like 3 megahertz is something that's going to be better superficially, right? And so it needs to be continuous, because continuous is actually going to cause thermal effects. Pulsed ultrasound is a non-thermal setting. And so if you're using pulsed ultrasound, you're not heating anything up, right? And then, so if you're doing high frequency with low intensity, you're not really going to get a lot of heating happening to that deep scar tissue, right? And then lastly, cryotherapy is actually going to make your skin tense up. And so it's not going to make things very extensible at all. And so you're going to make things really stiff and then massage it. And you may end up like breaking through or like damaging scar tissue further. So you don't want to use cryotherapy if you're trying to promote collagen extensibility. But good job on your guys' thought processes. Just remember, the higher the frequency, the lower the depth, right? That's one of yeah, ultrasound parameters. So fun, because you know how often I've used ultrasound in the 4 years that I've been practicing? 0 times. I have never used ultrasound. In fact, I never used ultrasound in my clinicals either. Okay, let's move on to the endocrine system. A patient with hypothyroidism presents to PT with a resting heart rate of 118 BPM and reports heat intolerance. What is the most appropriate exercise prescription for this patient? A. High intensity interval training. B. Moderate aerobic training with close vital monitoring. C. Resistance training only, avoiding aerobic work. Or D. No exercise until thyroid levels normalize. My CI hates on ultrasound every day. Well, yeah, because it's stupid. I mean, there's literally there's no support for it in literature whatsoever. Like, you look into all of these trials that they've done on like people who got ultrasound and intervention versus people who just got intervention. Not well, a different intervention, ultrasound plus the other intervention, and then just the intervention. There's no improvements with the use of ultrasound. These are like they're getting the same level. Um, so ultrasound is basically worthless, but you'll get out into clinic, especially if you work in the outpatient setting, and you're going to get bosses that are like, well, okay, I shouldn't dog on this because it's actually important, but people are going to be like, think about this three-legged stool approach, right? So we want to, in terms of offering the best care for our patients, obviously we want to do uh, what evidence-based practice says, right? And then the second leg of the stool is, what have I tried that has worked, right? And then the third leg of the stool is patient preference. And so if my patients think, there is evidence to suggest that if patients think something is happening, then they are going to get better. So that's kind of a crappy piece of it's kind of a crappy piece of evidence, but it's true. That's why placebo effect is a legit thing. Okay, talked enough. So I like where you guys' heads are at. Safety first, I agree. So hyperthyroidism, right? If we do high intensity, especially if we're not monitoring vitals, but if we do high intensity, we're running the risk of increasing cardiac stress. And she's already sitting at a high resting heart rate, right? And is going to have heat intolerance. So if we put her through high intensity, that heat intolerance is going to get worse. She may have um, excessive cardiac stress, which could then cause other issues, right? And so moderate aerobic training is going to be good because it's going to help increase um, it's going to help increase her level of exertion a little bit, but in a way that's safe because we're monitoring her safely, right? And so, reason that's not C is because it avoids aerobic training, which is unnecessary. We don't have to avoid aerobic training in people with hyperthyroidism, and it's going to limit the way that we can condition these patients, right? And then D, exercise is not contraindicated unless she's in a very unstable state. And if she's in an unstable state, that's when we're referring to the ED, right? So that was the answer to number 6. Okay, let's move on to number 7. A patient with Cushing syndrome is referred for PT. Which impairment is most expected? A, osteoporosis and proximal muscle weakness. B, hyperpigmentation and hypotension. C, hypoglycemia and weight loss. Or D, hyperkalemia and dehydration. Give you guys some time to answer that. For those of you that are joining, please forgive my noisy, crying daughter who is doing everything she can to avoid going to bed right now. Okay. In one word, somebody answer, with Cushing syndrome, why does this happen? You could answer it with one word. Excess in what? I'll wait. In Cushing syndrome, our body has an excess of what hormone? Cortisol. Absolutely right. Okay. So we know when we're in a state of, well, when we have excessive cortisol in our body, that's our stress hormone, right? And so we have increased stress hormone. It's going to put our body in a more fight or flight response. When we're in that fight or flight response, our body is like, okay, we got to harvest energy any which way we can. In order for us to have effective muscular contraction, we need calcium. So it's going to increase osteoclastic activity to break down bones, put calcium in our blood so that way we can use it for this fight or flight response because our body thinks something crazy is happening. And so, as a result of that, we get osteoporosis in the extreme cases. Sometimes it's just decreased bone density and not all the way to osteoporosis. And then this proximal muscle weakness is absolutely classic Cushing's. Super, super weak glutes. So you guys nailed that one. Very good. So this is a little bit different way of explaining that. You have excessive cortisol, which leads to protein catabolism, and then proximal muscle weakness and bone loss. So hyperpigmentation and hypotension is going to be seen more in Addison's disease. Cushing's is going to cause hyperglycemia and weight gain, not hypoglycemia and weight loss. And then cortisol excess causes sodium retention, not hyperkalemia, which is excessive potassium, right? Not excessive sodium. And so I'm going to go ahead and scroll to the next question. I'll read it really quick, give you guys some time to answer, and then I'm going to run to the restroom real quick. So, a patient with primary hyperparathyroidism is most at risk for which musculoskeletal finding? A, increased bone density. B, severe joint ankylosis. C, pathological fractures due to bone resorption. Or D, myofascial trigger points only. Okay, you guys go ahead and engage with this. I'm just going to run to the restroom real quick. Okay, let me look through what you guys said the answers are. Very good. You guys are crushing it tonight. Okay, so hyperparathyroidism. So excessive parathyroid hormone is going to increase osteoclastic activity, which is going to increase bone resorption, right? And then increase our risk for fractures. So obviously, A, it has the opposite effect. This would be in hypoparathyroidism. B, ankylosis is unrelated to hyperparathyroidism. And D, does not reflect systemic bone changes, right? Which is going to be very classic in hyperparathyroidism. What kind of PT prescription would you put this patient through? That's a really good question. And so, anytime any of my patients are going through decreased bone density, there's obviously it's really important that we get them into weight bearing as early as possible because those forces, those compression forces going through their bones is going to help stimulate osteoblastic activity. Now, don't get me wrong, PT, this is not going to be a PT alone thing. We need to be communicating with their doctor, obviously, to make sure that, like, hey, is her hyperparathyroid, uh, is her parathyroid stabilizing? Talk with them. Hey, talk to your doc. Make sure this gets stabilized because if the hyperparathyroidism is not addressed medically, then we are not going to be able to stop the process of the bone resorption, right? But we can try to have a mitigating effect, and once it is stabilized, we can help try to improve their bone density. So a lot of weight bearing activities, resistance training, because the tensile forces that our muscles are putting as they pull against our bones to move them, that's going to be really good for promoting osteoblastic activity. And so, um, I mean, it's not going to be necessarily anything specialized. Look at what they're bad at. Like if they're weak, they can't get out of a chair, then I'm going to do sit to stands, right? And by doing sit to stands, and if they can't do a full sit to stand, do mini squats. And by doing that, you're doing weight bearing, right? And you're doing resistive training. So you're hitting both of those angles of trying to improve their bone density. Another big thing I will do that probably maybe a lot of people do, but maybe a lot of people don't think their older patients can do is jumping. Jumping activities in a way that's not going to break their ankles, right? But anytime you put those compressive forces, those shock forces, um, it's going to help promote osteoblastic activity. So I love having my patients jump. I treat a lot of Jerry, especially with vestibular stuff. Okay, number 9, a patient presents with fatigue, weight gain, cold intolerance, and delayed relaxation phase of deep tendon reflexes. Which endocrine disorder is most likely? A, hyperthyroidism, B, hypothyroidism, C, Cushing syndrome, or D, pheochromocytoma. Dang, guys. You even let me finish the question before you jumping in. I gotta make these harder. Some of you guys are just like, dude, this is a cakewalk. Good job, guys. I don't waste too much time. You guys seem like you're crushing this question. So basically the opposite of what we saw earlier. You've got cold intolerance, obviously the opposite of heat intolerance. You have weight gain. So you have an underactive thyroid gland. When it's overactive, you get increased cardiac stress, right? You have increased metabolism and protein catabolism. Or no, sorry, that's with Cushing's. You have increased metabolism because of the hyperthyroidism, right? So hypo is going to be opposite. You're going to get fatigue, which can be common in hyperthyroidism as well. So you're going to get that weight gain instead of weight loss, cold intolerance instead of heat intolerance, and then hypothyroidism can delay the onset of muscular contraction, and so that's why you get this delayed relaxation phase of deep tendon reflexes as well. And so, A, you would show hyperreflexia and weight loss. C, this is going to produce central obesity, central meaning central like trunk, and proximal weakness, but no delayed reflexes. And then D would cause episodic hypertension and tachycardia. Pheochromocytoma is not going to be something I expect you need to know for the boards. This is just a distraction, and frankly, so is Cushing's. Because if you know your stuff, you should be able to narrow down right away to these two, right? That's going to be really common on your boards. You're going to have 2 answer choices that you should be able to like weed out pretty quickly. Then you're going to have 2. If it's not like you can go ahead and throw 3 right out of the book and you go right into the first one, then usually it's going to be okay. Those 2, it's not going to be those. The one because I've never heard of this before, and if I had heard of it, I would know. And because I haven't, I don't think they're going to test me on pheochromocytoma. So, but yeah, normally you get down to 2 and then you just got to pick the best answer. All right, number 10, our last endocrine question, and then we'll get to neuro. A patient with Addison's disease is beginning PT after hospitalization. Which vital sign response would require immediate modification of treatment? A, mild tachycardia during exercise. B, slightly elevated blood glucose after activity. C, increased perceived exertion with resistance training. Or D, orthostatic hypotension with dizziness. You guys go ahead, take some time to think about it, answer it, and we'll get into it here in just a second. I don't want you to answer this question now, the question I'm about to ask you, but if you guys want to start thinking now about what content areas you'd like to cover next on next Sunday's NPTE Night School, go ahead and start thinking about that, and I will pose that question again at the end, and you guys can help me create a list of what you guys think will be important. I should say not just next Sunday, but it'll help me create a list for the next several weeks, and I'll just make a big list. Hold on, Jess. I know gate. Everyone wants to do gate. I actually love writing gate questions, but yeah, I'll make a big list with you guys while you're still on the live, and then I will spread those out over the next like 4 weeks probably, of trying to hit all the topics that you guys said today. Okay, let's go ahead and answer this question. So the answer is D. So Addison's disease causes adrenal insufficiency, so you're going to have poor cortisol and aldosterone input, and so that's going to result in your orthostatic hypotension, right? If they're getting dizzy with orthostatic hypotension, that indicates the risk of them going syncopal and collapsing. And so this is something that we might need to modify immediately, so that way we can still work with them but not risk them passing out, right? Mild tachycardia is, I mean, that's normal, right? With exercise. CBP and endocrine, sorry. Going to bed soon, so putting my answers in. Okay. B, Addison's is more associated with hypoglycemia. And also, your blood glucose elevating slightly when you initiate exercise is actually pretty normal, right? It's like your body preparing itself for needing that energy of that glucose. So it's normal for in the first stages of exercise for your blood glucose to go up, and then you burn that off as you continue to exercise. And then increased perceived exertion with resistance training. That's, I mean, as a PT, I hope they have increased perceived exertion as I increase resistance, right? So that would be totally normal. That alone is not a red flag. Now, if this was going with some other stuff like chest pain, a substantial shortness of breath with like very minimal increase in activity, then I would be like, okay, yeah, I probably need to change. But with this alone, no, I'm not worried about that. Okay, number 11. This is where we get into our neuro stuff. A patient post-stroke demonstrates intact strength but significant dysmetria and intention tremor during reaching tasks. The lesion most likely involves which structure? A, the primary motor cortex, B, the basal ganglia, C, the cerebellum, or D, the posterior column pathway. Go ahead and take your time, think about it, and answer. While you guys are thinking about this, I also want to know, because I had some people last season, I'm calling them seasons because it makes me feel fancy, like I'm a show writer. But last season of NPTE Night School, I had several people from the Philippines. I had one dude in Florida that was on Eastern time zone, so the poor guy had to tune in at 9 p.m. his time, which made me feel bad. But yeah, that part sucks. And then I think I had some people from Missouri and Washington State and things like that. So if you guys want to, tell me where you're going to school or what state or country you're going to school in, and I can learn a little bit more about you. But I don't mind being on Eastern time and doing this before bed. Oh, dope. Well, sweet, Joe. This will work out perfectly for you. Because then you get a little study before you go to bed. Okay. Some of you have answered. Give you guys a little upstate New York, but I'm from PA. Dang. Billy graduated from SJU. I don't know what SJU is. I don't know what SJU is. I grew up in Arkansas, That's where I practice. I'm a Cornhusker fan, though, as you can see from my shirt. I went to school at the University of Arkansas for Medical Sciences, which is in the U of A system, but St. Joseph's. Okay, but it's not the University of Arkansas. I am not a Razorback. I do root for them from time to time, but primarily I root for the Huskers. Vermont, very cool. Arkansas, Gerald, brother. I'm also from Arkansas. Okay, North Carolina, Illinois, sweet. We got a good variety, like a really wide map of the U.S. right now. That's awesome. Okay, let's go ahead and go over this. So, if you know your central nervous system, then you ought to know that this discoordination, such as dysmetria, right, and intention tremor with reaching tasks, is a function, or rather a dysfunction, of our cerebellum, right? Is there anywhere we can get a copy of these questions? Florida baby wrestle gators and go to Disney. That's funny. I don't have Andrew. I don't have these written down, but what I do, the week following night school, I take this live and I post it to my YouTube channel, so that way anyone can review it if they didn't tune in on Sunday night. And so my YouTube channel is linked in my profile or whatever you call it on TikTok. So you guys will have access to this via YouTube after today. So hallmark cerebellar signs: dysmetria, dysdiadochokinesia, any sort of discoordination, but particularly intention tremor, right? Oh, perfect. Yeah, of course, dude. No problem, guys. Okay, basal ganglia is going to present more Parkinsonian, so rigidity and bradykinetic. Primary motor cortex is going to cause weakness and upper motor neuron signs like clonus, tone, things like that. Forgot about Danish. Shaking my head. Shame on me. Yeah, of course, Leica and Christian. And then posterior column pathway, if you're thinking of DCML, that's going to be proprioceptive deficits. You won't have any proprioceptive deficits with cerebellum. You're also not going to have any upper motor neuron signs and symptoms with cerebellum because none of the upper motor neurons arise from the cerebellum. So, will Parkinson's have trouble with overshooting and undershooting? I I wouldn't say Parkinson's will have trouble with overshooting, Bonnie. Um, you might categorize what they do as undershooting, but it's more likely to be bradykinetic because even with undershooting, there's like a speed component where like you'll notice they stop and then they correct it, whereas with Parkinson's, it's going to be very slow and it's going to take them a super long time to get there. Small, slow, hypokinesia, bradykinesia, things like that. So I don't think we would characterize it um, as undershooting necessarily. I think that the best term to describe those movements is going to be hypokinetic and bradykinetic. Do you have any resources or tips to learn the spinal tracts? There is a dude on YouTube. His name is the Ninja Nerd, and he does a really, really, really good job of teaching anatomy. I actually learned a lot about the actual physiologic function of the vestibulo-ocular reflex from his videos. And so you might, Edgar, check out the Ninja Nerd on YouTube. Um, Otherwise, just drill it, unfortunately. Okay, hold on one sec. I gotta unplug this so that way you don't see. Because I think I goofed up covering this. Yeah, I picked the wrong color for this one. Make sure that's not. Okay, cool. All right, we're getting close, guys. I'm sorry. I talk a lot and it's a problem, so you guys gotta keep me on track. How long does this go till? It goes until we run out of questions, Jess. So you guys stay as long as you guys want to. I'll be here until we run out of questions. Tonight I've got 15. So we've got just 4 more. I know I'm taking a long time because I'm meeting a lot of you guys for the first time. All of my other people graduated or took their boards already. And so, okay, a patient with Parkinson's disease demonstrates freezing during gait initiation. Which strategy is most effective to improve gait initiation? A, verbal cues of take bigger steps. B, rhythmic auditory cueing with metronome. C, strengthening of hip flexors only. Or D, walking backward. Absolutely right, guys. Yep, those external cues are going to be really, really important because essentially what we need to do is they've lost the ability to perform things that had a sense of automaticity to it, because those are typically unconscious processes going through our basal ganglial pathways. And in Parkinson's rehab, what we are focusing on is using the primary motor cortex and putting in conscious effort to bypass those basal ganglial timing circuits. And so external rhythmic cueing, like auditory cueing, is going to be really effective, but any sort of external cues can be really helpful. I like to use targets on the ground as well with my patients with Parkinson's, to try to just help with turning or breaking through any triggering environments like thresholds or things like that. Verbal cues alone are less effective for freezing, especially this is like an internal cue. Like, it's intrinsic feedback. It's not extrinsic feedback, right? And so if you know about motor learning, you know that extrinsic feedback is going to be more helpful in actually getting patients to do the movement you want. If you give them something where they're focusing on internal processes, it's not going to produce the level of movement typically that you want. And so weakness is not the primary cause of freezing, so strengthening hip flexors is going to be helpful. And backward walking might help, but it's not going to be my first line strategy. A lot of times, backward walking in my patients with Parkinson's is actually going to make their festination worse because they get anxious about doing it, which then causes more festination and freezing. Number 13, a patient with a T10 complete spinal cord injury, ASIA A, would most likely demonstrate which functional outcome? A, independent ambulation with AFOs. D, household ambulation with CAFOs and a walker. C, independent wheelchair mobility with potential standing program. Or D, full community ambulation without devices. My first C, I loved using music instead of just a metronome for Parkinson's. I think that's probably effective. It also, I don't think it's probably effective. I know it's effective. I also think that it's more salient to the patient, right? If you're putting on music, which is more fun than just like a tick, 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 right? And if you're getting music that they enjoy, then it's going to increase the salience, which is going to increase the fun, which is going to increase your patient participation, right? So that's actually a really good idea. I would like store that away in your toolbox for later for sure. Okay, a lot of you guys are submitting your answers. Good. Give you guys a little bit longer. I was on a clinical rotation at TIR Memorial Hermann in Houston. And that hospital, that rehab hospital, is absolutely dope. It's the best rehab hospital in the country. And like literally, it's ranked as the #1 rehab hospital in the country. And they have music therapists there. And I had a patient who had Parkinsonian features, but it was not Parkinson's that this person had. And we actually put a vibrating metronome on his ankle, so the vibration allows for like greater sensory input, so that way he could step bigger. And then we also had a music therapist who was playing guitar at that metronome rate, and so we were like working with music therapy to help our physical rehab, and it was actually really fun. I loved getting to work with the music therapists down there. All right, our answer is C. So T10, obviously too high. It's not gonna innervate our hip flexors to allow for swinging. We know that ASIA A is going to lack motor function below the level of the lesion. And so this person's primary mobility is going to be via wheelchair, right? With a possible standing program, probably with CAFOs or a standing frame, right? A would require motor function below the level of the lesion. Particularly if they're wearing AFOs, they need to have stability at those knees, which this person, if it's a complete injury, would lack, right? Household ambulation with CAFOs and a walker, because they don't have hip flexors innervated, which are innervated by T12 and L1, it's going to be a large energy cost for these people to be able to walk. And CAFOs are heavy. I mean, they try to make them more and more lightweight, but they're heavy. I mean, they're metal. So I doubt this person is going to do this. I mean, if they're ambulating, it's probably just going to be therapeutic in physical therapy. It's not going to be something that we're trying to do um, to get them walking more in the community or in the house, right? And then full community ambulation without devices. At this level of a complete injury, that's just not realistic. Okay, number 14. A patient presents with left homonymous hemianopsia following a stroke. Which functional deficit is most expected? A. Difficulty recognizing faces. B. Loss of central vision only. C. Diplopia when reading. Or D. Inability to see left visual field in both eyes. You guys go ahead and take your time and answer that question. All right, got some of you answering. I'll just wait a little bit longer so you guys can think a little bit more if you need to. Again, I was talking about this at the beginning of the live, but it's best for your learning if you actively engage. So even if you submit an answer choice that's wrong, I'm going to go over the answer choices. You guys are more than welcome to ask questions if I say something that is confusing, and I know I talk fast too, so if you need me to slow down, you can just say like, hey, explain that again but better. That's fine. I respond really well to direct feedback. Don't beat around the bush. Um, but actively engaging, even just hitting a letter on your keyboard, is going to help it stick more in your brain than if you just passively watch all of this happen without engaging in it actively. So, all right, all of you are absolutely correct. This is just a matter of knowing what homonymous hemianopsia means, right? So, homonymous, same side, hemianopsia, half of your vision, right? So, left field of vision lost bilaterally. Okay. Uh, A would be prosopagnosia, right, which is going to be an issue with the temporal lobe. B, central vision loss, is going to have to do with macular involvement. And then diplopia is going to be more related to an oculomotor nerve dysfunction. I definitely need to look into this. I'm brain dead tonight. You're doing fine, dude. Okay. If there's no questions about that, we'll move on to the final question for tonight, guys. A patient with Guillain-Barré syndrome is in the acute phase of the disease process, obviously. Which intervention is most appropriate? A, high-intensity resistance strengthening to prevent atrophy. B, aggressive stretching into end range to maintain range of motion. C, gentle active range of motion and monitoring for autonomic instability. Or D, endurance training to prevent deconditioning. Give you guys just a little bit longer. I appreciate you all engaging. It makes it more fun for me whenever I have people that are talking, because that just means that I'm not just reading off of a board, right, or a TV. Bro, how often do you do this live? I do this every Sunday at 8 p.m. Central Standard Time. I just came off of a 2-week break. I was taking a break for my own mental health, but also just so I could engage. You meaning typing? LOL. Yeah, it's more fun when you guys are talking, typing. But I do this every Sunday uh, at 8 p.m. Central Standard Time, so that way I try to do regular engagement because it's only going to be helpful if I do it if I'm consistent, right? And I just want to help people. That's why I got into PT, right? Because I want to help people, including students. All right. Most of you, if not all of you, got this one right. In the acute stages of Guillain-Barré, we want to do gentle active range of motion because we want to try to preserve strength as much as possible without causing further damage. We have myelin or demyelination happening. They're at a risk of autonomic instability, and so we want to monitor that. The reason A is wrong is because high resistance is going to risk muscle damage during the acute denervation process. B is wrong because aggressive strengthening may injure the weakened tissues, which then would cause a different kind of recovery after they stabilize and after they hit nadir. And then D, endurance training is inappropriate during the acute progressive phase because they're going to have no endurance and it's not going to help improve the process of the pathology to try to work endurance. It's more important that we try to do gentle active range of motion to maintain strength as much as possible, but we don't want to do uh, like high intensity resistive strengthening, right? So, all right, guys, that is it. Let me open up another doc so that way I can write down some topics that you guys want to cover. Nicole, someone said gait. I know that. I'll write that one down. Gait is actually a super fun topic. I love analyzing gait. Okay, so in the coming weeks, I want you guys to give me a list of things. I know that Nicole said cardiopulm and endocrine. Give me a list of what you guys would like to cover in the next several weeks. Luis wants to cover some cardiopulm. Sheen, we download the file. You're still the goat. Have a great night. Thank you for all you do to help us. Of course, guys. Interventions for MSK. Okay, let me write down farm. Okay. Oops. Postural drainage. Ooh. Joe, you're going to have to tell me what AOINS is. I'm not 100% sure. Farm, did I write that down already? Yeah. See you next Sunday. Pediatric milestones, reflexes. You got it. Good one. No problem, Edgar. You guys have a good night, dude. Can you suggest very high yield review materials? High yield, not for free, unfortunately, but if you guys don't already have the apps that have daily questions, I would start getting those, like PT365. There's some other ones. You can just Google some apps that'll give you some daily questions. When I was studying for my boards, my school bought score builders. They use something different now. I think I had heard they use Final Frontier, but now they have a different system that they take tests through, so I can't think of what it is. But I bought Final Frontier when I was studying, mostly just for the tests. I would say the thing that made me successful is I bought as many tests as seemed reasonable, and I took, including the 2 PETs that I took before I graduated, I took a total of, let's see, 1, 2, 3, 4, 5, 6, 7, 8, 9 practice exams. And so I think that's one thing that made me really successful. Interventions, good. Lymphatics. Lymphatics, non-systems. Oof, yeah, Bonnie. And I will try to do some differential diagnosis stuff because that is a whole section in and of itself, right? Like not a section that you're going to be tested on, like 1, 2, 3, 4, 5 section. Um, but content domains, I guess, is what I mean. What else did you say? Or Tavares, prosthetics. Metabolic alkalosis and acidosis. Yeah. I don't know if I finished my question earlier or my statement. My mind is obviously at the end of the day. Muscle activation, origin, and oh, I see you. I gotcha. Muscle activation, origin, insertion, derivation. AOINS, is that what you said? Action, origin, insertion, nerve. Gotcha. I'm with you now. Okay. All right, dudes. Yeah, of course, Luis. Vonnie, no problem. I'm glad to help. If you guys have any questions over the course of the week, feel free to DM me with anything in particular. I will post this live to my YouTube channel so that way you guys can review it if you want to, share it with your friends. That is just a resource for you guys to have. So that obviously my YouTube channel is all free. I don't just have a big thing that I'm willing to like. I've got several documents where I've got a bunch of practice questions on, but I'd rather engage with those over video. It is my work that I'm putting together, and so I have considered selling that portfolio of practice questions that I've developed. But I'm not super keen on. I'm kind of at a crossroads because I'm not super keen at charging students for stuff, but I also know that that's like my work and it's not nothing. Like I had to work to do that. So I'd rather just make a video and have you guys engage with it rather than me just like push out this big document of a bunch of practice questions because I think it's better for your studying if we engage rather than just reading over practice questions, right? And so anyway, thank you guys for joining. I will see you all next week and we'll cover some of these topics. Night, guys.